Good afternoon, and welcome to How IT Departments Can Battle Clinician Burnout with Presence, Transparency, and Action, a health system CIO production sponsored by Pro Tennis and Phrase Health. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the founder and editor-in-chief of Health System CIO, and I'll be your moderator today. We're looking forward to your participation. You can send in your questions or comments at any time in the Q&A box, and we'll take them later in the program. Just so you see how we're going to spend our time today, first we're going to go about 35 minutes with our main panel discussion featuring Mike Restuccia, SVP and CIO at Penn Medicine and the University of Pennsylvania Health System, Audrius Polakaitis, CIO and Assistant VP of HIT at UI Health, Nick Culbertson, co-founder and CEO of Pro Tennis, and Dr. Mark Tobias, founder and CEO at Phrase Health. And then we will have our Q&A. So let's jump right into it. Lots of good stuff to cover today. Mike, let's start with you. Can you give us an overview of your organization and your role?
Sure. Good morning. Thanks for having me, Anthony, once again. My name is Mike Restuccia. I'm the Senior Vice President, Chief Information Officer for Penn Medicine. For those that are unaware, Penn Medicine is the integration of the University of Pennsylvania Health System and our Perelman School of Medicine.
Excellent. Thank you, Mike. Audrius?
Hi, Audrius Polakaitis. I serve in the role of Chief Information Officer at UI Health, which is an abbreviated version of the University of Illinois Hospital and Health Sciences System. We are a university academic health system, obviously a patient care delivery organization together with 7 health science colleges, basically training about 1/3 of the clinicians that practice in the state of Illinois.
Very good. Thank you. Nick?
Hey everyone, Nick Culbertson, CEO and co-founder of Pro Tennis. We use AI and automation to help health systems reduce risk by replacing manual and tedious auditing steps. Relevant to this conversation, we see our product helping reduce burden on clinical staff from doing a review of auditing by leveraging the power of AI to reduce false positives and ensure that any investigations are not going down a wild goose chase and distracting from clinical staff. But just excited to be a part of the panel today.
All right, very good, Nick. Thank you. Mark?
Thanks for the invitation. Mark Tobias, CEO and founder of Phrase Health. My background is as an emergency physician. Did a clinical informatics fellowship where was really focused on electronic workflows and the EHR, and specifically looking at clinical decision support. Ultimately founded Phrase based on that research, and now we're helping health systems kind of do this work of reducing burden, reducing clicks, and really understanding an extraordinarily complex system that is the delivery of clinical care.
All right, very good, Mark. Thank you. Okay, Mike, we're going to start with you. We want to sort of set the stage for the discussion, and I think certainly the idea here is that clinicians are at a premium. They're the lifeblood of a health system, and we can't take their happiness lightly. So that goes to workforce challenges about them being at a premium. What macro trends are driving shortages? And what IT, obviously this is the bigger part of the discussion, what IT related issues may be contributing to clinician satisfaction, and we'll get into how you can figure out if they are and those kind of things. But Mike, your overall thoughts just on this clinician workforce issue, because that's obviously going to permeate the messaging that IT gets from overall leadership about, hey, you can't be contributing to dissatisfaction here, or if you are, it has to be addressed.
Yeah, I think if you start at the macro levels, there's a variety of factors that are impacting shortages, not only across our country, but it's global at this point. And so, certainly most folks are looking at the impact of COVID and the pandemic and the burden it placed upon clinicians to be on the front line, while probably all of us on this call, many of us at least, perhaps Mark was in the ED, I'm not sure at that point, but we all retreated back to the safety of our homes, and clinicians went to the front line and fought that unknown, mysterious illness at that point in time. And It wasn't for a week, it wasn't for a month, it was for years. And I think that drain on individuals certainly had clinicians, whether nurses, physicians, therapists, whatever, frontline personnel, reconsidering perhaps what they should be doing with their careers and their lives. I also think there's a second point to this, which is, could this just be a generational change and individuals looking for more and more personal time and me time versus the exhaustive hours that clinicians tend to put in over time. So, I think some of those are just headwinds. At Penn Medicine, we've experienced the turnover as the rest of the industry has. And we're very keen and very focused on, so what do we look at from an IT perspective? How do we reduce that burden? Less clicks, certainly. How do we engage our clinicians more so they're more involved with the development of our systems? And I would say we have dozens of governance groups that include clinicians to try to optimize their satisfaction. But I think what is really interesting, and heard from Mark and Nick in particular from their vendor perspective, is how are we leveraging technology and AI to sort of advance and reduce some of the redundancy and repetitiveness that exists within our systems, and how do we actually provide assistance and give something back to the clinician versus always asking them to give, right? So more on diagnosis, more on patient identification, more on revenue cycle, more on compliance. We're always asking them for more. How do we give something back? And predominantly what they're looking for is more knowledge and more time so that they can spend with their patients. So that's my summary, as we prepared for this, Anthony.
Excellent, Mike. Thank you. Audrius?
Yeah, everything Mike said, I agree with. I want to focus on two things here. One is this question of burnout. Inevitably, as Mike pointed out, COVID induced burnout, and it was very real. I would contend that now, after the fact, burnout has been a popular thing to talk about. It is, I would say, I at times feel burned out in my role. And what are the things that burn you out as a professional? Is this relentless onslaught of activities and demands that seemingly never is stopping? This is sort of one of the things, one of the hallmarks of burnout, where you feel you can't pick your head and grab some air. Essentially, we just talked about in the preamble here about back-to-back Zooms. I realize that's that is one of these characteristics now we see. Different in the clinical setting where we're talking about life and death situations than, as Mike pointed out, those of us who are sitting in our offices or in our homes. But burnout is a persistent thing. Within IT, one of the best ways for us to help that, we can't help it all, is to focus on workflow. Because even as professionals, not in clinical settings, I think there's nothing that drives us more crazy than platforms and systems that seemingly don't integrate. Like when we're dealing with our own administrative or HR platforms, sometimes you scratch your head and you're like, what? Like, again? Like, you need me to do this? These annoyances in our workflow. So a very keen focus on workflow seems to be one of the ways to address this. Another one is all of our major enterprise platforms, especially our EHRs these days, are instrumented to be able to at least get an understanding of how different clinicians are doing as they try to complete various tasks. Epic has it, Cerner has it, many of the major platforms have this. It's developing maybe an expertise to better understand, what do I read? What kind of insight do I glean out of that data? That is data, it's not insight. There needs to be some interpretation of this to understand who is really struggling. The data can give some insight there, but it does follow usually with individual conversations with folks that seem to be struggling to understand what they're struggling with and how we can help both them individually and collectively as they are part of a larger group practice.
So, Audrius, you're talking about these tools, the EHRs, they do have the ability to provide you with data on usability, even at the individual user level. but you saying you need to focus more on that and to develop an expertise in that and to better draw out the conclusions that that data can give you. Is that correct?
Burnout is multidimensional, multifactorial, but one of those factors is inefficient workflows and processes. And part of the challenge in a workflow may be simply a gap of knowledge. And to identify those people that are struggling in using the tools, maybe others are using them more effectively, identify those people that are falling behind and figure out a way to engage with them, to understand what are they doing, what's the gap in knowledge that may help them get just a little bit more efficient, maybe then help a little bit with that burnout.
Very good. Nick, your thoughts?
I want to stress, I agree with everything that Mike and Audrey said, but I want to stress something that Audrey said about focusing on the workflows. Physician burnout is such a multifaceted problem, and I think it's important to acknowledge that IT and technology alone can't fix the problem. You know, there's individual factors like the healthcare role, personal factors like family dynamics. You know, not just healthcare was affected by the pandemic and the economic climate post-pandemic, but individuals were, spouses were, families, children's, all that kind of stuff. Individual skills and abilities and how they are meeting their work, whether they're leading with delegation, empathy, or what kind of management style they have, et cetera. Then there's the external factors where I think IT plays a heavier role when it comes to things like regulatory or business or payer environments, organizational factors like bureaucracy, a culture of collection, and you know, a learning and practice environment, how well the health system is set up to support a learning or budding clinician, especially if it's an academic setting with residency. So I think all of these come to play, and I think IT focusing on workflows is incredibly important because that's one area that really feeds into supporting clinical frontline. You know, they say in healthcare that healthcare teams are not built on independency or dependency; they're built on interdependency. And the most important thing that IT can do is do their job. And if IT is running really well, and physicians know that when they're leveraging their tools and they're working as expected, that's the table stakes. That's the bare minimum, making sure that the group is working. And from there, it's about optimizing workflow and making sure that teams are well supported. I'll go back to my introduction. One of the biggest things we see is compliance programs that are asking physicians or clinicians, nursing staff to get involved with compliance, to get involved with regulatory demands, to make sure that those boxes are checked and that we're supporting and reducing risk across the organization. But that's not the primary mission of a clinician. We're saving lives. And so the more you can take that work off of the clinical staff and allow them to focus at what they do best, back to that interdependency, I think is so important.
You know, Nick, maybe just a quick comment, Anthony. You know, IT ends up being the enforcer of the regulatory environment, the enforcer of compliance issues, and we end up on the bad end of this conversation because it is our platforms that are forcing these things. I think that's the point you were making. Yeah.
Yeah, and also, Audrey's, what Nick was saying about always asking for more, right? Always asking for more clicks, more participation, more things to do to help the organization comply with the
Right.
program.
I don't need the clicks. I don't want the clicks, but somebody somewhere, right, said this is now important, and now they turn to the CIOs and say, how can we automate that? How can we make this? How can we add this to the workflow? And this is where, yeah, this is where it gets
right.
off.
So the perception is that this is an IT requirement when it isn't. You're just sort of in the middle doing the data collection, and that there's a perception issue.
Now, maybe fair enough. We need to be more creative and figure out ways in surrogate manners to gather that data. But sometimes if you approach it straight on, right, it's very forced. It's adding extra things into the workflows, which just burden everybody.
Mark, what are your thoughts?
Yeah. So again, I agree with what everyone's saying. Just to piggyback on the last few comments, I think there's been a trend, especially with the EHR, of a lot of clinicians feeling like they're data entry clerks, and are they practicing top of license? So yes, for compliance reasons, billing reasons, whatever, they have to put in all of this information. into the system, and is that duplicative? Is it appropriate? Is it needed? I think are always questions that need to be asked of the people who are implementing these interventions or these tools. And then I think the other question to kind of think about as we move forward, and I know AI is obviously top of everyone's mind these days, but I personally think that a big change in at least the physician perspective between how it might have been perceived a few decades ago versus today is the accessibility of information for consumers or patients is ubiquitous at this point, and I actually think that's really good and empowering for patients. But clinicians are being inundated with questions and patient dictated care to a certain extent. And how are these AI tools going to further kind of deprioritize the clinician experience, clinician education, where they feel empowered to make decisions and not feel like they're being questioned, not just by their patients, but now by AI tools that are being implemented into the clinical environment.
All right, very good. Excellent. Mike, let's start with you. You know, I've broken this into sort of phases. Prevention, and then we'll talk about optimization. But let's first talk about prevention of dissatisfaction with IT tools. What can IT leaders do before the selection and implementation of technologies that will offer the best chance of satisfaction? Mike, you mentioned dozens of committees, and that scared me a little bit because that sounded like something that could get excessive. So anyway, your thoughts there.
Sure, it could certainly get unwieldy, but I think the basic concept is you need to engage with your clinical community. And whether that's we as IT leaders or partnering with members of the clinical community, whether it's the chief medical information officer or the chief nursing information officer, who quite honestly have more credibility with their colleagues in the clinical staff, understanding upfront what's working, what's not working, what are the areas of most need, what's the prioritization of those needs. That to us is almost table stakes and first and foremost. You really have to engage with your end user community, and whether you do it through committees or other methods, you have to gather that info and get input in some way, shape, or form, and then react to it. And you know, a lot of the comments here are spot on. There really are no bad ideas. No one ever really suggests something that is totally out of bounds or is just on a whim. They're all trying to improve care. They're all trying to make things more efficient. They're all trying to optimize workflows. They're all trying to do their job and trying to do their job in the most effective manner. And so all these requests do come into us from an IT perspective. And then it's up to us to work with our colleagues through whether it's a governance committee or other methods to prioritize and then implement. Engagement is really key there.
All right, very good, Nick.
Sorry to make sure I wasn't on mute. Yeah, I think I just want to stress again the level of interdependency and supporting teams when it comes to prevention. I think one of the I was still reflecting on the number of committees too, and I think asking all parties to get involved can be counterintuitive because it's asking people to step out of their way to get involved with projects that may not be on their radar. But doing that first is certainly better than asking later in the process when people haven't been informed and they have to catch up to what's going on. And I think this is the real challenge for healthcare leadership too, is making sure that strategically the organization is aligned and that initiatives are picking up in a cadence where everyone is able to support them. Because at the end of the day, everyone has their initiatives. As Audrey said, but with the compliance, you may be pushing that out because it's really important for IT to achieve that requirement, but that might not be on the top of mind for clinical staff. And so really making sure that the organization's aligned on strategically what is most important so that every individual group or division is prioritizing the work and that we're not creating more work for each other.
Very good. Audrey's?
Hey, I want to defend Mike. I don't think Mike suggested that the more committees, the merrier, right? But the point I think he's trying to make is through the committee structure, you have an opportunity for clinicians to get involved in the decision-making process. And so you're trying to lessen that feeling of something being done to them, rather they're part of that decision process. So I think everybody said it already. First thing I think about is workflow, workflow, workflow. If you're bringing in new technology, you better understand how this fits in with everything you have and how it impacts the way things will get done and who's being impacted. If you're not paying attention to that, I'd say you're almost being negligent. The second thing that comes to mind is the power of the CMIO. It's already been noted, but leveraging that capability, whether it's a formal CIO or more informal with physician leaders, that is the conduit. Physicians don't mind talking to me, but I think they much more would rather talk to their peer who can more commiserate with what they're feeling. Now, after the fact, which I think we're going to get to, I'll talk about education and rounding, which has its own interesting challenges. But if we're talking about prevention, yeah, it's focusing on workflow, making sure we're not destroying people's workflows and their professional lives at work by introducing something new that seems like a great idea, and then having that conduit into the physician community and the clinician community.
Perfect. Mark?
Yeah, I'm just going to put a plug for the clinical informatics kind of field as a whole. It's relatively nascent and new, so a lot of organizations, I mean, I think academic medical centers have largely kind of bought into this concept of the importance of formally trained clinical informatics teams. But my general perception is that these teams are really under-resourced, and I think at the end of the day, it's really hard to kind of show ROI for informatics, which is why I think they're ultimately under-resourced. But I mean, I've heard it equated to an elevator in a skyscraper. Everyone knows that they want it. They know that it adds value, but how do you kind of understand the true quantification of what these informatics teams are doing? And as Idris kind of alluded to, having a CMIO who's really empowered to engage with the clinicians, to understand the workflow, to ensure that these tools are getting implemented appropriately, and importantly, to iterate on that, not just to say, hey, we implemented the tool, check the box, move on to the next thing, because maybe it's not performing as expected. And really the people who have their ear to the ground, the ear to these clinical environments are going to be the ones who are going to be able to enact that iterative improvement.
Mark, what are your thoughts on sort of the need to continue practicing to some degree to keep that sort of street credibility for a CMIO type individual? Is it possible if you stop practicing, you might be out 3, 4, 5 years, you're still a CMIO, you maybe not using the tools, maybe you're great at managing the whole process and making sure things are working, but what are your thoughts on that? Keeping at least, and I know one person who just, it's another ED doc who's been on the vendor side for a long time, who I think does 1 shift a month. So it's not a lot, but it's just
Yep.
something to keep your involved. What are your thoughts?
Yeah, so I was going to say the exact same thing. So I still do some clinical practice. I do about 3 shifts per month, which I personally find very rewarding. But importantly, I think it also informs kind of the work that I'm doing. And I think, I mean, I'll kind of defer to the CIOs on the call, but I think it does show some credibility, whether you're talking externally as a vendor to a potential partner organization, or if you're internal as a CMIO, to be able to kind of talk to your colleagues and have them not point to you and say, you don't know what I'm going through, you haven't practiced in 10 years. So I do think there is importance, and the vast majority of CMIO positions that I see do require some percentage, at least a nominal 20% or whatever, I think for that very reason.
Yeah, makes perfect sense. All right, very good. Next question, Audrey. So let's start with you. Now we'll talk about optimization. How can IT leaders work with both users and vendors to ensure the applications being leveraged are as good as they can be and continually improving? A lot of times, Audrey's maybe most of the time, things, if you're sourcing issues among the users with the tools, taking actions to fix those issues are going to be the responsibility of the vendor, right? Because I don't know how often you can get in, you're not getting in there yourself and tweaking. Maybe there's some user customization that's allowed. Maybe some of it's got to go back with the user group, the vendor user group, and you sort of put in your request and maybe it gets put on their roadmap. But what are your thoughts there?
Yeah, Anthony, it's a combination. Obviously, some core capabilities we won't be able to, that are missing. We won't be able to do anything independently about. We're going to have to work through the various vendors that support us to have them build in those capabilities or those, let's say, integrations within their tools. But there's a heck of a lot you can do with configuration, with setting up workflows, with the way you're presenting information. And here the best way to do this is to get out with the community and understand what they're seeing, what they're experiencing. One of the biggest gaps that we identify is education, and yet it's one of the hardest gaps. So sometimes people feel things aren't working for them, but you realize, but you're not doing it right. If you did it right, like this would work a lot better. Back to these instrumentations that we can maybe get a sense of that, but it's one of these interesting paradigms, or maybe paradoxes, maybe is the right word. Like if somebody would invest 20 minutes to get a little bit more educated on what they're doing and how they're using the tool, they might save themselves 4 hours a week. I'm making up these numbers, obviously. But to convince a clinician who's focused on clinical care to care enough to invest 20 minutes to learn, let's say, a tool a little bit better, it's a hard sell. Candidly, it's a hard sell for me. I mean, every time I get into one of our HR, workforce management tools, I try to do something and I don't forget how to do this. And I could, the same medicine, like, buddy, spend some time learning it and you'll get better instead of trying to, figure it out every time you're in there, right? And trying to do it anew. So there is education is a really important aspect, yet it's hard to find how to get that motivation for people to get educated who think that their role, and rightfully so, their role is clinical care. The second thing is rounding. Rounding is a wonderful tool. I don't do enough of it. I need to do more of it. We have members of our team that round together with our CMIOs. And sometimes, right, you walk through the floors and you grasp your head in what you see, right? And you're like, what? This is what's happening, right? Which you never would have had any insight. You intended it to do a certain thing. It ends up doing something else. And you only get that insight through rounding it, through seeing it in action.
That's such a great story, Andreas, and maybe that's sometimes why you don't want to go, right? Because you don't want to take that walk because you say, "Oh my God, what am I going to see?" There's stuff sitting
So
over
this is
here
being the ostrich with your head in the sand, right? Which is a strategy,
that
sure.
works for me. That's what my wife says. She says that's my general reaction to bad news is denial of it. But it works. Like you said, it can work. No, we're all just kidding around. Very funny. Mark, what are your thoughts?
Yeah, I mean, I was just thinking about what Audrey was saying, and I was talking to one of my colleagues, and they were talking about how the EHR was kind of one of the banes of their existence, and they just hated working with it. And in this case, it was Epic, but this could be any EHR vendor. They were like, well, Epic does X, Y, and Z, and this is what Epic is doing. And I explained to them, actually, this is totally managed by your local organization. And there is the possibility to do this change. And I think there was this disconnect of feeling like they were not empowered. And I think these EHR vendors oftentimes get a bad rap. And it's not because the health system is purposefully trying to make their workflow difficult or onerous, but they just didn't even realize that they could get involved in that change. And I think this kind of dovetails back on the talk of governance groups and how to get involved and how to engage these end users, because I think one of the few things that actually has been shown to really improve some of the experience in some of these things is with education and really making sure people understand the tools and then making sure the tools are responding in a way that work for those clinicians.
Yeah, a lot of great stuff in here. Mike, what are your thoughts?
Well, piggyback on Mark's comments, since they were supportive of my committee discussion. You know, you indicated up front, Anthony, that you pose the questions in a phased manner, with one of the end results being, how do people feel they're being heard? People generally don't feel they're being heard if they're responding to a survey or if they're doing something, tangential like that. But they do feel like they're being heard if there's one-on-one communication or they're part of a committee. Remember, we're a big place, 50,000 plus employees, 6 going on 7 hospitals, and with every specialty and subspecialty available. And so each one of those environments, whether inpatient, ambulatory, home care, specialty, they're all unique and require their own set of inputs and capability of people being heard. Now, a lot of people are heard. It doesn't mean that we respond to each and every one, but I think the comments here were great. Like, you have to align with your strategic plan. You have to align what's most germane to your department needs. Dermatology is different than cardiology, which is different than transplant. Like, how else are you going to allow your end users to be heard if you don't have something like this structure in place? And then I think the second thing is what several people have mentioned is the role of informatics and shoulder to shoulder support. Being out there on the front line, and it's great when I walk through, but people look at me and they're like, ugh, what's he doing walking through here? Versus somebody that really knows what the heck they're doing and can actually coach someone along the way and say, you can do this in 2 clicks versus 8 clicks. That person's really valuable to them versus someone like me. It's good for me to observe and then come back and try to adjust. It's even better when we have those frontline people out there, and that to us, from an informatics perspective, has been really beneficial.
Hey, Mike, I would comment that, ironically, right, the thing that's most impactful, as you indicated, is the one-on-one attention. And yet that is by far the absolutely hardest thing to scale.
It is, yeah.
And this is the challenge, right? You'd love to be able to sit with each person and see what's going on, and help them out, if they'd be willing to commit that time. But how do you do this across thousands of clinicians? That is the grand challenge I feel we face.
But is that a testament to that some of these systems are just too complex for clinicians? I mean, we spend a lot of time kind of focused on usability, user experience, and these EHR systems, I mean, for good reason, are extraordinarily complex. They cover all these service lines that Mike referred to. They have to do billing, they have to do documentation, they have to deliver labs and all of this stuff, but it's like flying a plane, and clinicians didn't go to school to learn how to use a super complex electronic system. And I wonder if kind of this focus on education is really kind of shining the light on some of these enterprise tools are just not made to be as usable as they should be.
Anthony, if I could just piggyback on that, with, I think, a recent occurrence that several of us, if not all of us, participated in, which was the CrowdStrike scenario and failure a week and a half ago, almost 2 weeks ago. Interestingly, to Mark's point, those, we did a debrief and continue to do a debrief. Those clinicians that have been practicing for quite a while, we went back to them and said, what was it like with the outage that took place? And those that practiced for a while said, it was really nice. We went back to paper. We spent more time in front of our patients. It was like the old days. The newer clinicians that only know the digital world, their hair was on fire. Like, I didn't know what to do. I didn't know how to, where the paper was. I didn't know where the pencil was. So, I think there's this balance between complexity and practicality. And the CrowdStrike scenario really brought that to light for us, that some people are really happy with this situation. Like, take your time. Don't worry about it. Others like, when's it coming back? I need it.
Very good. Nick, your thoughts?
2 thoughts. One, just adding on to the current conversation and how important training is. We see this a lot. Our program needs to work with whatever input data, whatever medical record or other peripherals are being used. And we often work with customers as they transition from one medical record system to another. And we see it in the raw data where time in record for a single individual, their average time to see a patient or whatever workflow they have, will drastically increase during that time you go through a transition, but not equally. You can see differences in cohorts, and you can see different entire organizations. And the organizations that are the most efficient at a transition are the ones that accompany the transition with a robust training program. The thing I wanted to add on that going back to how IT leaders and vendors can work together, one thing that I'm seeing more and more, especially as everyone is trying to be more efficient, is the lack of conversation around QA. As we use more artificial intelligence enabled programs, the adage can't be more true that good data in equals good data out. And a lot of times vendors require customers to do the quality assurance, the QA process, and ask clinicians or other individuals to take time out to review, to give feedback. And I think this is becoming an increasing problem where, you know, the expectation should be that the vendor is competent in really making sure that the quality of data that's going in is sufficient to get the end results, and that there's not an expectation of you bought it, you have to now maximize it to your satisfaction. So I think that's a cultural thing that's developing, especially as everyone's trying to be lean. Vendors want to be lean, health systems want to be lean, so no one wants to do it. And I think there's a little bit of a pushback here, but I can say I think it is the responsibility of the vendor to make sure that the product you're buying is being used fully effective without you having to put a lot of manual effort into assuring that.
I think it's a great point. Mike, I saw you, I believe you were laughing when Nick was talking, and probably in agreement. What are your thoughts?
Well, I think his comment about QA and my comments about CrowdStrike, just piggybacking on that, was ever more impactful. Yeah, the importance of QA, and otherwise you bring the world down.
You know, Nick, I don't know if this is a good analogy, but it makes me think of the self-checkout at the supermarket. It's like you used to do that, and now I have to do it, right? They just offloaded the work to me. They save money on less checkout people, and now I'm standing there trying to figure out where the barcode is. Anyway, it just felt similar there. All right, let's talk about, oh, this is yeah, this is a good one, because I think this is super important. I think any kind of approach or system that is expecting the users to respond and report problems, and that if we're not hearing any complaints, everything's fine, I think that's deeply flawed. Many times when I run into an issue with something I'm using, I get irritated and I may not have the time or interest in reporting the problem.
You know, whenever you do surveys, lack of participation in the survey can be a good thing or it can be a bad thing. It can mean that everyone has good satisfaction, or it could mean that people are so frustrated they're not responding. So, Mike, you want to start us off talking about feedback from clinicians and really understanding what the pain points are?
It ties back to my earlier comments. You need to have a process in place, and our process tends to be governance committees and tends to be people out walking the hallways. I don't think it's anything magical or overly mysterious, but it's back to that term I used up front, engagement. And I think the good news for me in an organization like this, I have many CIOs at each of my hospitals and entities, and they have staff that are constantly out working on the nursing stations and in the ambulatory clinics. Overall, it's my judgment or my theory that 80 to 90% of the evaluation of the IT team is generated by the support provided by our desktop support personnel, our clinical engineers, or an IS service desk. Not any of the other fancy folks that are, parading around, but that engagement on a one-on-one basis is really where we get the most feedback from.
And we tend to be proactive, as the slide had indicated, right? And we always are preaching log an issue, report an issue. But it's sort of one of these things, once it happens, like, oh, you want to say it's too late, right? I would rather not have it happen to begin with. So it's the same strategies that Mike was alluding to. It's about rounding, it's about getting out, having your connections, having your governance groups. to get a pulse of what's happening and what are the areas of satisfaction, dissatisfaction. I want to go back to rounding, and it's amazing the things that come out of rounding, which you didn't think were happening, and you realize they are happening, and you're embarrassed by them, and then that's a motivation to go do something about it.
Yeah, I want to emphasize, I think one of the things that was mentioned earlier around kind of making sure that what people are putting into the system, they're getting value back. And there's a ton of data in these systems. I mean, the EHR in particular, but obviously other IT tools as well. And one of my informatics colleagues published a paper called Cranky Comments, where just by looking at the comments coming back from the alerts in the EHR, they did some sentiment heuristic on that, and they were able to identify almost 30% of their alerts were malfunctioning in their EHR. So why not use the data that people are putting into these systems to understand the malfunction and act in a way that you're not asking them to fill out another survey? So that's a tool that we implemented in our system, implemented in other interventions in your tooling. So how do we have evidence-based ways that we're kind of collecting existing data to surface these opportunities? Because getting people to fill out surveys when they get home or after the fact, I had one colleague refer to clinicians suffering in silence. And it's kind of that thing where they kind of clock in the work, bang their head against the wall, go home. The last thing they want to do is fill out a survey to say that this alert fired or this tool isn't working for them.
Perfect. All right, let's have a little fun, and we're going to go with our Ask a Co-Panelist segment. Nick, we're going to start with you. Do you have a question for one or more of your co-panelists?
Yeah, I'll direct this both at actually no, I have a question real quick. Mike, how many committees do you serve on?
Do I serve on? Dozens. I chair or well, I don't chair any. We co-chair everything with operational leaders, but I co-chair 5 different committees.
Andres, how about you?
Yeah, it's probably a half dozen that I'm directly involved in, and then probably another dozen with my direct reports.
So that's interesting. So a combination of your direct reports, being able to delegate some of the responsibilities out to the different governance committees.
Yeah.
Okay. No, I appreciate that. I was curious. So no, my question was actually, I have to go down the AI path, and I want to ask a targeted question about artificial intelligence because I know so many health systems are exploring it. My question is, where do you think AI is going to have the biggest impact in the next, I want to say 24 months? So very near term look, bigger impact on reducing cost or bigger impact on employee or patient satisfaction? Because this is the big promise that all AI and healthcare is talking about. And I'm curious what you're seeing or what's being effective, positive or negative on either of those fronts.
Maybe I'll jump in. A topic that's been debated in many circles. I think the ambient documentation solutions are really, and I realize we're talking about generative AI, not predictive AI, but that seems to be really the thing that people are pegging a lot of hopes on these days. That fundamental disconnect that we have if you don't have such a solution in place where you're having a conversation with a person, your face is in the computer, or you're spending hours at the end of the day catching up. And I don't understand how clinicians remember which patient they saw and what each patient said to them, right? So that, to me, that's a game changer. So I would vote on this this aspect of maybe improving engagement, improving job satisfaction.
Anyone else want to jump in there?
So I'll jump in, and I took the somewhat unpopular position in a leading edge organization like the University of Pennsylvania Health System and Penn Medicine that's known for advancements and world-class clinical care and everything else. And 6 months ago, stood up in front of a large group, national group, and said, my presentation is titled "Why AI is a 4-letter word and how it can become a 3-letter word," and in parentheses, wow. And very much to Nick's point, there's so much hype around AI, and as an IS leader, and I'm sure as operational leaders, we're getting bombarded by every organization and vendor that believes they have something that's called AI, which sometimes it is and sometimes it isn't. Sometimes it works, sometimes it doesn't. The premise of my discussion was in non-clinical settings, AI will advance, to Nick's point, more rapidly because there's more of an appetite for failure and trial and discovery. And the implications for failure are generally recoverable. To be throwing some of these tools into the midst of a patient care workflow that may be accurate, may not be, until we are 110% sure, I think we have to be very cautious. So although I thought I had a catchy title and got people interested, I think the message was very much what Nick had indicated is non-clinical will move faster, whether predictive, generative, whatever. On the clinical side, I would even argue that ambient listening, which we are pretty heavily engaged with on both the physician and nursing side, brings some benefit, but it's not necessarily on the clinical care side yet. It's more on the time saving, perhaps on the coding. There's an awful lot of time our doctors still have to spend reviewing the note that comes out and making sure it's file pro. It's the non-clinical side is, I think, in 24 months afterwards. And I took the popular position of, yeah, it's going to be great. This hype is going to come to fruition and it's going to work out great. But I got an earful by titling it that and presenting to a national group and getting that feedback. So far, I've been right.
I would agree, Mike. I've heard this say a similar saying, make AI boring again.
Yeah.
Awesome. Very good. Mark, do you have a question for one or both of your or more of your co-panelists?
Yeah, I mean, I think for everyone, because I face it even as a small company that uses our own vendors, but there's kind of this out of the box versus customization, and I know very popular topic when it comes to EHR systems, and Audrius, I know UIC kind of went live recently with Epic as an example, but how do you draw the line between when is it appropriate to do further customization, getting at we got to make the workflow right, we got to hyper customize to this unique workflow that we have, versus saying, well, then we're going to have to maintain this very custom workflow. The vendor might not support it in the future. So kind of this balance between maintenance, customization versus trying to stay out of the box, I think is a big challenge. Love to hear your thoughts.
Yeah, spot on. We were on the Cerner platform for 20 years, had customized the bejeebers out of it, right, to the point where challenges taking even upgrades and updates. Learning from that lesson, when we deployed our most recent EHR, which happened to be Epic, we very much tried to adopt a standardized approach and would challenge our clinicians to say, please don't tell me what you want, but tell me why this workflow doesn't work. And if there was a valid argument, we'd be willing to make that investment to make adjustments to it. But generally what you find is when you have an organization, again, using Epic as an example, with that kind of breadth of organizations, really good organizations that they work with, they usually have culled the best of the best. Are there gaps? There are gaps. We try to fill them as best we can, oftentimes then turning to the vendor with sort of exasperation saying, why doesn't this work? This should work. This seems to make sense. But I feel we have a very good relationship with Epic, with the Epic team, and they generally are responsive to our needs. Of course, as everything, maybe not as quick as we would like to see them be able to come up with these developments, but ultimately they come out with effective solutions for us. But it is this constant balance. I'd say it's more of an art than a science. I don't have a perfect answer for you.
Yeah. And it's, I mean, it's also kind of gets back to the comment around kind of increasing the complexity of these systems. It's like, well, further customization creates additional complexity that may work for that one workflow, but then other people are going to need education and training to learn about it. So,
the only thing I would say is when people are involved in the customization, you've got something unique. You now are a little bit beholden to that resource who created this uniqueness. And we've had situations where a person wrote a platform, was being used, that person left the organization, literally became a farmer, no joke. Like he decided to change his career, right? And now you're stuck with, what do I do with this thing, right? That this is the person who was the expert, he no longer is accessible to us. And obviously that's a tough situation to be in.
Mike, anything you want to jump in there?
From a question perspective, I'll share that we are significant users of the Protenus solution. We like it. It helps us a lot. And it generates a lot of discussion internally regarding people's access to data and records and things like that. So we're big supporters. But I thought since Nick was on the panel, to the extent he can, could he share one of the more colorful discoveries that the Protenus tool may have found at a institution, and not necessarily obviously giving away anything confidential, but I thought it'd be colorful and sort of intriguing. We have a whole variety of things that are popping up all the time that the tool discovers. I'm wondering how ours compares with maybe what he sees from a macro perspective.
Appreciate that, Mike. You guys are a big name brand, and so the activity can be very varied. But I joke with our team that we sometimes have the same challenge that an organization like the CIA has, and that we can't really talk about our successes because they've been contained and can't really measure what could have happened if that had gone ungarnered. I will say the thing that's really surprised me over this time is anyone in the news has something going on at a health system, whoever it is, politician, athlete, celebrity, they're being treated somewhere. And people are always looking for details on that. And I'm always disheartened to see how constant the approach is. I think one of the most interesting things that's come out of our research is when we look at some of the most nefarious, egregious breaches, we find that it's very rare that it's their first time. And usually what happened is those individuals were building up behavior towards that. And they might have even been detected in something that was maybe a benign policy violation or sloppy practice, but not enough to really raise the spotlight on them. And what we found is by identifying those early warning signs, the people who are going down the slippery slope, you can prevent those more egregious incidents over time. Terms of color,
Come on, Nick. You can't do it? You can't do it?
Try to think of a really good one that I can be anonymous or ones. I think some of the more interesting ones usually tend to be love triangles, where different relationships are coming to play and getting in the way of individuals. And then I think there's a very fine line between benevolency and questionable nature. We hear a lot from our customers, the comments like, oh, I know their birthday was coming up, but I couldn't remember what day. So I just needed to peek so I could say happy birthday to them. And it's like, well, let's not break the law to say happy birthday.
Yeah. Good ones.
Awesome stuff. Awesome stuff. All right. Let's do a final round of best pieces of advice. Just framing this up as we want to be responsive. If I could say, if I could think of two things that would be the most irritating, you talk about burnout, Audrey. He said when you feel like you can't come up for air or you're not getting anywhere, you're not moving things forward. We talked about the idea of being heard. Certainly, if you're frustrated and you feel like you're not being heard and nobody cares, that's going to be burnout. If somebody's listening to you and nothing's happening, that's going to be frustrating. Unless you're told why, meaning it's going to happen, it just hasn't happened yet, right? So education, like we touched on so many important things that can alleviate the problem, and many of them are doable, right? Because a lot of this isn't, I need Epic to make a change next week. Well, that's not going to happen, right? But many of these things have to do with listening, letting people know they're heard, trying to take actions based on what's needed, and then communicating back either when or why it's happening or why it's not happening.
Listen,
So
it
what,
sounds so
yeah,
easy.
yeah,
Like it sounds so easy, but it's hard.
yeah.
Right?
So
I
your
mean,
best,
the basic principles are all somewhat obvious, right? When you lay them out the way you did. Executing consistently in that way, being constantly open to feedback, not getting defensive when you get the feedback, being able to put things in action in a sufficiently quick
Mhm,
manner that somebody
mhm.
feels they were being heard. These things do get complicated.
And it's all got to be scalable, right, Audrey? So everybody talks about, yeah, at the elbow support for someone who wants it and is willing to put in that time is maybe the best. But number one, not everyone wants it because they think either I shouldn't need this, you figure it out, make it better so it's intuitive or whatever. But that's scalable issues there. So best piece of advice, final piece of advice, based on your experience and what's worked for you, what you feel has been effective. What would your parting advice be? We'll go around the horn. Mike, let's start with you.
Sure. I think in closing, you might reframe the point a little bit. IT departments deliver a heck of a lot of value and effort, and you know, there's always people want more. They want more at the restaurant. They want more at their hotel. They want like I get so one of our I think secrets to success, because I do think we've delivered quite a bit. The results of surveys indicate high level of adoption, on a national basis compared to others. And so, generally we're doing things right. We could always do a little bit more. And part of the way I think we build that credibility is certainly number one by delivering, communicating, but also sharing what has been done
Mm-hmm.
since the last time we've met. People, I'm guilty of it in my life, and you forget what was done. All you know is you want more and more and more. So, I wrote down engagement, communication, and follow up are the keys.
And Mike, I know you have that big report you put out, right?
Mhm.
So that's part of your secret sauce is, hey, let's let people know about our wins and let's not say, this is us tooting our own horn and we don't want to do it. No, it's not the case.
No, the Phillies are in a slump right now, but let's not forget that they won 3 games like up to this point.
Great. Audrey, is your final piece of advice.
Yeah, I thought the Phillies were in first place. They got the best record across the
Yeah,
entire
like
Major League Baseball, right? Yeah, yeah,
But I
yeah.
think they lost last night, if I'm not
Ah,
correct.
they're
Go
good.
ahead.
we
Go
all
ahead.
can't be perfect, right?
Yeah.
Um, everything that Mike said, right on. The one thing I would add is get close with your CMIO. That is a
Mm.
really key, and I like the way Mark abstracted it, the informatics community. They're a key asset, a key partner. I reflect upon myself, really have been focusing on developing that relationship. My CMIO and I were supposed to have an hour-long conversation Friday afternoon. We went an hour 45, right? Because there's so much to talk about, so much insight to leverage from him and the team that he works with. They are going to be one of these key enablers to various strategies and things that you want to accomplish.
Such a key partnership. Excellent. Mark, your final thought.
Yeah, I mean, he took exactly what I was going to say. Really, I just want to plug clinical informatics as a field, their importance as an extension of IT, but also as the conduit for kind of understanding local change and local workflow and empowering them with resources and data to kind of do their job effectively. I just think is so incredibly important.
Awesome, Mark. Nick, we'll give you the last word.
Today we were talking about physician and clinical burnout, but I just want to acknowledge everyone's burnout. We all have really important roles and really important responsibilities. I think the number one thing that we can all get better at is being very transparent about what our priorities are. Anytime I come in a conversation and someone starts with, hey, this is what's really important to me right now, and this is what I'm working for, conversation is 10 times easier because then I can say, I can help with that or I can't help with that. And I understand you've got what's important in front of you. I'm going to be transparent what's important to me, and we can just get cut to the chase because we both are busy and have important work to get done.
Absolutely. All right, wonderful. That's all we had time for today regarding continuing education. You could use the final slide in this deck. You'll get an email when the on-demand recording is ready for viewing, and if you want to work with us, you can reach out to Nancy Wilcox from our team, and you go to our website to register for upcoming panels. With that, I want to thank our wonderful panel, Mike Restuccia, Audris Polakaitis, Nick Culbertson, and Dr. Mark Tobias. And I want to thank Pro Tennis and Phrase Health for sponsoring and you for attending. With that, everybody.